Good afternoon, everybody. Thank you very much, Barb, for your invitation to be here in this wonderful country. So I am going to talk about the concepts to be a traumatic in the surgery of the inner ear. That is not only related with the cochlear implant surgery, it's even related with another surgical procedures we need today to implement at the level of the inner ear. So today are working in a regular way doing cochlear implant surgery, but is coming another procedures like vestibular implants, is coming the surgery for drug delivery, is coming surgery for gene therapy that I'm going to talk tomorrow, and also even to take some samples of the inner ear for diagnosis purposes. So it's very, very important for surgeons and for ENT in general to know the anatomy of the inner ear from different angles, from different approaches, because this is one of the key factors really to be traumatic in the surgery. So this is the reason why I'm going to speak about surgical anatomy of the inner ear. So the index for these instructional courses is like you see, why surgical anatomy of the cochlea, macroscopic and microscopic anatomy, surgical approaches to the cochlea, cochleostomy, cochlear implant surgical anatomy, vestibular implant surgical anatomy, and conclusions. So first, we are going to take the view of this inner ear from a macroscopic and microscopic point of view. This slide came from Rax Anderson. Thank you very much, Rax, for this wonderful work and this material that is very useful for us. So you can see in general the different parts of the inner ear area and where is placed each of one. So you can observe here the cochlea. Let me check if I have a pointer. Yeah, we can have the cochlea with the basal first and second turn, and is very close, especially the basal turn, to the carotid artery. You can observe here the cochlear aqueduct is coming to the scala tympani in the basal turn, round window, oval window in this place, how the facial nerve is coming in the second, third portion, and the posterior labyrinthine with the superior semicircular canal, lateral and posterior semicircular canal. How is in that case the jugular bulb? Okay, so this is another angle to see the same structures. So in that view, we have just in front of us the aspect of the semicircular canals. It's very interesting to understand how is the trajectory of the vestibular aqueducts that came from the posterior fossa. So you can observe here the endolymphatic sac and how the vestibular aqueduct go into the vestibule in the posterior wall of them. And also you can observe in the internal auditory canal how the different nerve components split. Observe here how is the facial nerve. This is the ganglion, geniculate ganglion. How is the vascularization at that level, the second portion of the facial. And here you can see how the cochlear, the vestibular nerve is coming to the vestibule. And here you can observe behind the cochlea and the cochlear nerve in this portion. It's interesting, observe the subarcuata artery go in the center of the superior semicircular canal. This is another view, a macroscopic view of the internal auditory canal. You can appreciate better where is the entrance of the cochlear nerve in the modulus of the cochlea, And again, observe where is the endolymphatic sac and the vestibular aqueduct that is going into the vestibule in the posterior wall. With more details, we can check again the internal auditory canal. How is the cochlear nerve going into the modiolus in the cochlea? It's very interesting, this anatomical aspect when we are speaking about some kind of malformations where we have or we don't have a development of this modular section of the cochlear nerve. And also you see the relation between the basal turn and the carotid artery. So it's also very important when we are working in some ossified cochleas at that level, and how we have more or less 8 millimeters from the level of the round window to the end of the basal turn of the cochlea, just before go against the artery. A new detail about the cochlear nerve going into the of the cochlea in the modiolus area. And this is another view of the internal auditory canal, especially of the fundus. We have here the perforations through the modiolus for the cochlear nerve. This is the entrance of the facial nerve in the first portion, intralabyrinthine first portion of the cochlear nerve. This is for the superior vestibular nerve, and this is the inferior vestibular nerve that is going to the medial part of the vestibule. Now we pay attention about the dissection of the cochlea. So we remove the lateral wall of the cochlea, and again you can see here the basal turn, the first and second turn, the modiolus, the lelicotrema, where the scala tympani is communicated with the scala vestibuli at that point, and the lamina spiralis that is split the scala vestibuli to the scala tympani. And how is the connection, the scala vestibuli to the vestibule, where we can find the otolytic organ. All this macroscopic view is correlated with the microscopy of the inner ear. So in this slides, you can see most of the structures that we are going to need to approach to the cochlea. We can observe the foot plate, the vestibule, the middle ear space with the hand of the malleus. This is the incus. You can observe in the lateral wall of the tympanic cavity the A nerve, the chorda tympani, the Eustachian tube, the relation of the Eustachian tube and the muscle of the malleus, the internal auditory canal, and how the different components of the acoustic and facial nerve are into the internal auditory canal. So it's important to pay attention about all these details, because it's very interesting to, for example, to establish or to design the approach, in that case, to the scala tympani of the cochlea through the membrane of the round window. So you can see how our approach in, for example, the cochlear implant surgery go through the mastoid, through the posterior tympanotomy between the facial nerve and the chorda tympani, and how we can get this space that corresponds to the scala tympani. Again, we can observe how nice and how is the section of the cochlea. This is the scala vestibuli, the Reisner membrane, tectorial membrane, organoid corti in the basilar membrane, the scala tympani, the lamina spiralis, with the dendrites of the first neuron of the cochlear nerve, the spiral ganglion in the modiolus, and this is the axons of the modiolus. This is the spiral ligament and the stria vascularis that is very important for the metabolism of the inner ear. So with more details, the organoid corti. Well, how important is to analyze in each of the patients that we are going to treat the correlation between this morphology, the size of these areas, and also pay attention about the tonotopic distribution in the cochlea of the different components in this animal. So everyone knows that the cochlear shape is different from one another patients, and you can see different examples of these anatomical variations in the shape of the cochlea. Well, we are going to address our attention to the surgical approach of the cochlea, and as you know, in a standard way is to go like this, drill a hole in a hole in a hole. So we are drilling first a hole in the mastoid, the second hole in the facial to approach to the facial recess, and the third to open the cochlea at the level of the cochleostomy. So this is the work that we are doing during the surgery, and you can see again in this slide, histological slide, how we are creating a straight approach to the scala tympani. This is very important to be a traumatic when we are approaching this part of the cochlea through the round window membrane. So this is a macroscopic view of this approach. It's a dissection between the facial nerve and the chorda tympani, and how in this trajectory we found the round window and then the scala tympani in the basal turn of the cochlea. It's interesting this preparation to observe how is the vascularization of the facial nerve. It's very, very strong, this vascularization. So you can see all these vessels at different levels, third, second part, and even the genicular ganglion in this level. So this means that, for example, when we are doing the compression of the facial nerve, we can observe all these bases. So sometimes we understand that the medial approach to the round window during the cochlear implant surgery can be necessary. So it's not easy. And also you can produce damage in this vascularization at that level. Well, at the end, after perform the posterior tympanotomy, we are approaching the posterior wall of the tympanic cavity. And in this area, we can see different structures. This is the pyramidal eminence where the stapedius tendon came, and also you can observe in this area the stapedius muscle. These anatomical landmarks are very important sometimes when we are trying to reduce the facial nerve area, just to have a better approach, a better view of the round window needs. It's interesting in the cholesteatoma surgery to understand where is the sinus tympani, because it's one of the areas where we can find some cholesteatoma lesions. And see how the facial nerve came from the third, second portion, oval window and round window and hypotympanon. In some cases, we have misplaces of the electrode array. So because they are introduced in these grooves of the hypotympanon. So take care about that. observe where is exactly the round window niche and where is the round window properly. About the cochleostomy, is one of the main steps in the cochlear implant surgery. We can see here the cochlear wall. If we drill the lateral wall of the cochlea, we can have access to the scala vestibule and to the scala tympani. This is the area of the round window. We have some papers related with dimensions of this lateral wall of the cochlea that can be useful to know what is the distance between the lateral wall to the different components of the inner ear at the level of the cochlea. So all this was published in the Acta Otolaryngological with the collaboration of Fred Linticon from the House Institute. Well, so during many years we were talking about promontorial cochleostomy, and really it's a big mistake in terms of atraumatic surgery of the inner ear, because I demonstrate the promontorial cochleostomy addresses you directly to the inner ear, especially to the spiral ligament and the organ of Corti. So today we are speaking most of the times about round window niche cochleostomy, round window membrane cochleostomy. So we are going to describe all these different cochleostomies in the cochlear implant surgery. The round window membrane, extended round window membrane, round window niche cochleostomy to get to the scala tympani first, and cochleostomy, promontorial cochleostomy to give the approach to the scala vestibuli and others cochleostomies. This is a figure that represents the view of the surgeons through the posterior tympanotomy of the tympanic cavity, and we represent here the scala, the round window niche. Here is the tendon and the stapes, and we can represent the basal turn at the division from the scala vestibuli to the scala tympani. So if we are trying to get the scala tympani through the round window, we must know that the round window most of the time is hidden in the niche. How to localize this area, especially in some difficult cases where we have inflammation, where we have, a difficult anatomy of this area. So the main landmark is the oval window. In most of the cases, the distance between the inferior part of the oval window to the superior part of the round window niche is 2-3 millimeters. And in this area, we'll find the round window membrane that is the entrance to the scala tympani. So we need to have a straight trajectory with our electrotherates to the scala tympani. If we like to obtain this straight trajectory, we need to drill the edges of the round window niche, like I saw in this slide. This gives the opportunity to have a straight trajectory away from, or far away from the lamina spiralis, membrana basilar, and spiral ligament. Take care about drill the superior part of the round window, because in this area you have the attachment of the spiral ligament. If you damage this area, you produce also damage over the membrana basilaris. So important just to expose properly the round window membrane to have this straight trajectory to the scala tympani. This was described very well.
Your time is up.
So what to do? We follow, or it's not for allow? Well, So we continue. So the other question is, round window is round? No, it's no. In most of the time is oval, like you see in this work from Arturo. Most of the time we have different shapes of the round window area. So the standard round window membrane cochleostomy is to drill the crista fenestra in the inferior part of the round window niche. The problem of that is that we produce damage over the endosteum of the scala tympani. Also, we accumulate some bone dust in the scala tympani. We have a very nice trajectory for the insertion, but in terms to be atraumatic, there are some problems when we extend the round window. And also, it's very important to take care about this point that corresponds to the cochlear aqueduct. If we drill 2-3 millimeters away from the round window, we produce damage, and at the end we lose the hearing in that cases. So round window niche cochleostomy means to approach the scala tympani, drilling in the area of the niche of the round window. This is very important to avoid go forward where we found the round window, the scala vestibule, not the scala tympani. Related with the first term, cochleostomy, we can select this point for special cases where we have some ossifications into the cochlea. The place where we are going to drill is the anterior part of the oval window, a little bit inferior, just to obtain the approach of the first star of the cochlea in this point. Promontorial cochleostomy to get the scala vestibule, in some cases of ossification of the scala tympani, we can go there. So we need to drill in the superior part of the round window, and in this point we'll have the scala vestibule, but it's not a good idea in terms of traumaticity, because when we drill this promontorial area, we are going to go through the scala tympani a little bit, but especially through the spiral ligament organ of Corti, just to get the scala vestibule. And when we perform that, we are very traumatic. We'll have ossification in long term. And promontorial cochleostomy, well, this is the area, so we can perform this kind of drilling just to expose the spiral ligament. Maybe it's necessary in some cases for the future when we need to approach this area of the cochlea. It is possible from robotic point of view to do that in a very nice ways. Like you see here, this is the cochleostomy, and you see a very nice preservation of the spiral ligament and the different components of the cochlea. So it's possible to do that, but we need some micro tools, or we need some special tools to help us. About cochlear implant surgical anatomy, so, well, this is a very important slide that came from some of the experiments we had with macacas. So this is an electrotherapy, it's a stray electrotherapy. This is the round window. The round window must be preserved during the cochlear implant surgery. We need to perform a very nice work.
Doctor, your time is up.
Well, sorry. I don't know if it's allowed to continue, so maybe if what to do. Sorry, but so just to say two things. First, it's very important to open the round window with a small incision in the anterior inferior area of the round window membrane. No use suctions, avoid bleedings or bone dust in this area, and to know that natural healing of the round window membrane is produced after 24-72 hours. we have a natural healing of the round window membrane. So this is very important in terms of preservation of this structure for the future. Maybe we need to go there. It's very important to deliver drugs from the middle ear to the inner ear in this part, and you see the nice fibrous capsule that is around the electrode array without any damage in the spiral ligament, basilar membrane, and other components of the inner ear. I'm going to go faster. Importance of trajectory, so we were speaking about that. This is what happened with a scala media vestibular insertion. Always when you have this ossification. And just to say that we are working in the field of the vestibular implants, so we study different approaches to the vestibule. We are using vestibular implants for the stimulation of the macula of the utricle and sacral. And we study, for example, the posterior approach to the vestibule between the lateral semicircular and superior semicircular canal and the crus communis is one of the possibilities we have. And the second one that we are using today is to perform a double approach, one for the cochlear implants through the round window, and also to the foot plate to perform a platinotomy close to the anterior crura, and in that place to have the possibility to perform a platinotomy with a laser, introduce the electrodes of the vestibular implant, like you see in this slide. This is the cochlear implant, this is the vestibular implant through the foot plate to stimulate the vestibular inferior nerve in this part. So, conclusions, the cochlea is no untouchable organ, so we can approach them. But it is important to know this anatomy, to know that we are going now not only achieving a hearing rehabilitation through cochlear implants, we need to preserve the structures of the inner ear, and even to know that if we add the corticosteroids, we are able even to control the electrode insertion trauma that we can produce. But in the future, we are trying to achieve these aims, neural protection, neural regeneration in the cochlear implant surgery, and is very close to have this new approach. Thank you very much. Sorry by the delay.